just from his home or somewhere with a desktop, with a laptop. Unbelievable, but superb. Yeah. Superb. Okay. Okay, that works. Okay. So good afternoon, dear colleagues. I like to start this symposium. My name is Ingolf Cascorbi. I'm happy to co-chair with Dr. Erika Cecchin here. The session, it's on genomic biomarkers in cancer therapy response. You know, this one challenge in cancer therapy is, of course, response on the one side and toxicity on the other side. And it is, of course, a matter to diagnose the intracellular mechanisms leading to resistance of drugs and sometimes also to toxicity in individual patients. And that's we try to address in this symposium. We have 4 larger talks. The largest talk will be given by Dr. Cecchin, and maybe a short talk. We are waiting for the one who will present this talk. And so I'm happy that we have talks here from Europe, but also from China. And the first talk will be given by Dr. Erika Cecchin. She is a scientist and researcher at the National Cancer Institute in Aviano in Italy. And she is being exceptional in pharmacogenomics of colorectal cancer, worked a lot with UGT1A1 and DPYD. But more recently, she focuses also on clonal selection of novel deleterious somatic mutations and regulatory factors of gene expression. And she will speak about germline and somatic pharmacogenomics to refine colorectal cancer therapy. Erika.
Thank you very much, Ingolf, for the kind introduction, and thank you also for the invitation to be here today and to talk about germline and somatic pharmacogenomics in the field of colorectal cancer therapy. And I will focus also part of my presentation on biomarkers of tumor response in a specific niche of colorectal cancer in patients that are locally advanced rectal cancer. So just some number about the epidemiology of colorectal cancer, that is still the second most lethal cancer and the third most prevalent malignant tumor in the world, with a lot of new cases diagnosed every year and a lot also of tumor-related death. And despite the impressive improvement in the screening methods and in development of new pharmacological treatment, still the 5-year survival expectation is very low, especially in the metastatic stage of the disease. And here I've reported a timeline of the introduction of an amazing number of new drugs with the new pharmacological targets that are still under development in the last 20 years. But as you can see from this cartoon, from this picture, chemotherapy still plays a very important role in treatment of colorectal cancer and is still at the backbone of almost every chemotherapeutic regimen, every pharmacological treatment at every stage and setting of the disease, since it was demonstrated to improve very much the survival of those patients, and that's why it is still considered and included also in association with the target treatment. And the chemotherapy can be given both as a single agent treatment, especially fluoropyrimidines, and also in association with other agents as oxaliplatin and irinotecan. But as we know, chemotherapy, despite the important effectiveness in curing those patients, is also burdened by an impressive number of adverse drug reactions that are also impacting the financial, that have also an impacting financial burden on healthcare systems, and that should be considered as a factor that could be prevented in the clinical practice. So I will focus the first part of my presentation about germline profiling of patients to prevent toxicity from chemotherapy to colorectal cancer. And however, when we look to the clinically relevant germline gene-drug interactions in colorectal cancer, we can see just the two hotspots that are UGT1A1 for irinotecan and DPYD for fluoropyrimidines. So I will bring you some data about this gene-drug interaction, DPYD and fluoropyrimidines. As you know, DPYD is an important and a pivotal catabolizing enzymes in the pathway, metabolic pathway of fluoropyrimidines, and is in some cases at very low function and expression and can cause an overexposure to the drugs with a related important toxic effect. And we know up to date that some variants in this gene can be the cause of this impairment in the activity of the enzyme and can cause the toxicity and can be used to detect in advance those patients that could be at risk. So I've reported here a couple of studies that we performed some years ago. The first one was in 2015, and we tried to validate the effect of these variants in a large cohort of cancer patients with different, from the real world practice, so with different kind of tumors, different kind of treatment association regimens, and still we were able to demonstrate that the variants were significantly impacting the risk of toxicity. Later, we also validated those data in collaboration with our colleagues in Leiden University in specific regimens of treatment where capecitabine and fluoropyrimidines were given in association with the radiotherapy. There is a kind of skepticism among clinicians treating patients with radiochemotherapy to reduce the dosage of fluoropyrimidines, since fluoropyrimidines are used at a very low dosage in those patients, and they are just adopted as a radiosensitizer. So they are not very confident in reducing the dosage in patients that are carriers. But we were able to demonstrate that still the reduction of toxicity related to the, I don't know if there is a point. That the reductions related to the reductions of adverse drug reactions in patients that are carriers of the variants and that received a reduced dose was still poor. And we have also, again, a higher number of percentage of toxic events in patients with a reduced dose and carrier of the variants. So highlighting the possibility that in patients chemoradiotreated, maybe a lower dosage, even a lower dosage of drugs should be given. But focusing more on the colorectal cancer patients, this recent study that we published on more than 700 patients treated with the fluoropyrimidine-based regimen focused on the clinically relevant toxicity. So we decided just to consider those toxicity that are impacting the clinical practice in terms of dose reduction and of interruption of the treatment. And applying the gene activity score approach to categorize patients according to the predicted functionality of the protein, we demonstrated again that especially acute toxicity was very much increased in those patients that were carrier of a defective gene activity score. So you can see that patients with a gene activity score of 1 can have an increased risk by 10 times of developing a severe clinically relevant toxicity. But you may ask me at this point, okay, but if we know the genotype, we can save 9 events of severe toxicity. And on the other hand, we should genotype more than 700 patients to save just 9 toxic events. So is it cost effective? How many patients should you have to genotype to save 1 adverse drug reaction? What is the number needed to genotype? And how much does it cost to the healthcare system? That's why we move into the field of pharmacoeconomy, just to try to figure out what was the balance of the cost between genotyping patients in the clinical practice and saving costly toxicity. So we focused again on colorectal cancer patients that were treated with fluoropyrimidines-based regimen, and we collected all the costs related to the management of their toxicities. And of course, the main cost item that we found was related to hospitalization, that is this one in blue. And hospitalization costs appear to be significantly related to the presence of pharmacogenetic variants in DPYD. So you can see in this graph here that carriers have a higher cost related to hospitalization along all the course of treatment. And this was the same case also when you consider all the costly toxicity, so not just hospitalization, but all the other potential items. And of course, when we compare the average cost per patient to treat the toxic events, we demonstrated that they were significantly different and that a carrier costs to the healthcare system more than 2,000 euros more to treat their toxicity as compared to a wild-type patient. In a further step, we decided to focus on a panel approach. So as I told you from the very beginning, we have another hotspot of pharmacogenetic in colorectal cancer that is UGT1A1 coupled with irinotecan. So we consider a panel-based approach to evaluate the combination of DPYD and UGT1A1 star 28 and how their combination could increase the cost in patients that were carrier of either one of the variants. And again, we were able to demonstrate that carriers cost much higher than non-carriers, and especially with the panel approach, we were able to identify a higher percentage of costly patients, and this could certainly increase cost effectiveness of the approach. So now pharmacogenetics for DPYD is a reality in Europe. So from 2020, May 2020, a recommendation from EMA was published, and this changed completely the clinical practice of colorectal cancer, I mean, of all the patients treated with fluoropyrimidines in the clinical practice that now are more likely to receive a test before receiving the treatment. But when we go back to the number, we can notice that even if DPYD variants are effective in identifying patients at risk, just a small percentage of toxic event will be prevented by genotyping the patient. So almost 90% of patients experiencing toxicity are not carriers of the 4 DPYD variants. And when we look at these two very interesting, in my opinion, papers, and we had the authors of one of them yesterday presented at the pharmacogenomics session, is data from his group about the paper in which he, that is this one, oh, sorry, that is the one published on British Journal of Cancer in 2020, but a similar message is given also by the other paper, that is that when you consider the 4 genetic variants that are covered by the panel recommended by EMA and by pharmacogenetic guidelines, you will explain just the 74.6% of the predictive variability related to the genotype. So it is expected that, especially for DPYD, as compared also to other ADME genes, as for instance TPMT, you will have the possibility to find new variants that are likely to be predictive and to increase the sensitivity of the test. That's why we focused on rare variants, and we know from the literature that many reports have been already reported about cases of extreme toxicity to fluoropyrimidines related to specific private variants that were reported maybe just in one case in the literature. So how we were trying to figure out how this kind of finding could be translated in the clinical practice if every patient has its own specific mutation. How can we know from the very beginning how to adjust the dose and how to identify a patient who is at risk if every patient has a different mutation? So we performed this study in which we applied a next-generation sequencing approach to sequence the complete DPYD gene and compare the results between 2 groups of patients. So one group of patients with toxicity, severe clinically relevant toxicity to fluoropyrimidines, and another group who acted as control. And all of those patients were not carrier of the 4 DPYD variants that are included in the guidelines. And then we coupled this approach with an in silico functional analysis done in collaboration with the Karolinska University and the group of Professor Lauschke. And we were able to demonstrate, at least in this first pilot study, that when you perform a next-generation sequencing analysis and you select those variants that are relevant from a functional point of view with a specific dedicated tool that was developed specifically for DPYD, the burden of rare and functionally relevant variant is significantly higher in patients with toxicity as compared to patients without toxicity. And here you can see the table in which the numbers are reported. So we discovered that the patients that were carriers of at least one rare variant with a functional a missense variant, because the tool was developed for missense variant, so a variant that has a functional impact on the protein, the patient has a 16-fold increased risk to develop an adverse drug reaction in the first part of its treatment, and then 11-fold increased in the later course of treatment. And this is quite common with the genetic variants, where the effect of the genetic variants are apparent in the first part of the treatment immediately after receiving the drugs. Here you can see reported the location of all the codons and amino acids that were mutated in the patients with toxicity. So to conclude this first part related to the germline markers of toxicity, we can say that chemotherapy is still the backbone of colorectal cancer treatment, and so we must still deal with its effect and also with the toxicity related to its administration. And that the DPYD and UGT1A1 genotyping could certainly increase in the prevention of toxicity, and now DPYD is currently tested in the clinical practice in Europe in many countries. But the sensitivity of the test is still very limited, and probably the use of NGS, if validated, and of course if also all the economical aspect and logistical aspect must be clarified for sure, but this pilot finding could pave the way of an approach that we could consider also for the clinical practice of patients with colorectal cancer and all the patients treated with fluoropyrimidines. So in the second part of my talk, I will try to focus on the pharmacogenomic biomarkers of treatment efficacy in colorectal cancer, but especially, as you have seen from my very title, I will talk about locally advanced rectal cancers. So locally advanced rectal cancers are a subgroup of patients with colorectal cancer that are these tumors originating from the rectum, and they are good prognosis. In most cases, tumors that are just a locally advanced stage of the disease. They are managed with a multi-approach treatment, so they receive a combination of chemo and radiotherapy, and then they can undergo surgery, and so there is room to improve the selection of patients for different combination of treatment based on the characteristic and the risk of the patient. So in the first place, we performed this meta-analysis trying to figure out what was the role of markers already used in the clinical practice of colorectal cancer in the specific subgroup of patients with a locally advanced disease. And as expected, we were not able to replicate the same effect that we observed in the colorectal cancer in this subgroup of patients, but most of all, probably because the studies are very small, data are very heterogeneous, so it's very difficult to highlight a signal of significant effect of somatic mutation, for instance, in RAS, RAF pathway, TP53, and so on and so forth. But the only effect we were able to highlight was the effect of KRAS, that was a detrimental parameter for the response to treatment in patients with locally advanced rectal cancer, as also in the colorectal cancer patients. But in this case, the effect was completely independent from the use of cetuximab. So it was not related to the drug, but most likely related to the, we hypothesized it could be related to the backbone of the treatment, so aggressiveness of the tumor, but also to the administration of chemoradiotherapy to those patients. So just let me show you more, just a little bit more in detail what is the clinical model that we adopted and why I think it's very interesting to be applied, to be used for a biomarker discovery approach. So rectal cancer patients at the time of diagnosis are assessed for the risk to develop poor response to treatment or to develop bad longer-term outcome in terms of disease-free survival and overall survival. And based on those evaluation, a specific neoadjuvant fluoropyrimidine-based chemoradiotherapy is delivered to the patient. Then afterwards, a clinical evaluation of the tumor response is performed, and based on that clinical evaluation, a proper surgery is considered. A surgery that could also be avoided in some cases of good response to treatment and be replaced by a water weight strategy with a preserving organ option. But how this stratification is done at the time of diagnosis, it is just based on clinical parameters at the moment. So invasion of a specific tissue within the pelvis, and number of positive nodes, and other clinical characteristics, but it is completely lacking the presence of genomic or molecular biomarkers that could be helpful for the stratification. And that's where we try to figure out what could be our contribution to the optimization of treatment in those patients. And we decided to adopt a pharmacogenomic approach related to the immunogenetic hypothesis. So we know that radiotherapy and chemotherapy is given in those patients in order to achieve a local response because the disease is localized, but then the patients die for metastases. So it's very important to control the disease also at distance, with the distance, to control the development of distant metastases. And we know from the literature that interaction of fluoropyrimidines and radiotherapy can stimulate the immune response against tumor and to develop the so-called abscopal effect that was demonstrated to control the development of metastases. And moreover, we know that some immunoscore that were developed in colorectal cancer are also valid in LARC. And also we have very recent evidence that in specific molecularly selected patients, immunotherapy is very effective in those patients. So we try to start by a panel genetic polymorphism analysis focused on 63 different genes related to tumor microenvironment genes transcription, regulatory genes, and we found a significant signal from 3 different SNPs that are not in linkage disequilibrium among them on SMAD3. SMAD is a family of proteins that are playing a role as downstream effector of the stimulation of TGF-beta that is triggered by chemoradiotherapy treatment, and that can trigger also a suppression of the immune response due to the activation of the downstream pathway. So we observed that polymorphism in one of those proteins were related to the tumor response to the treatment. So not a prognostic, but a predictive factor. So we decided to integrate. We think that probably, since we are talking about the tumor, but we are also talking about the interaction between tumor and tumor microenvironment, the combination of the genetic profiling with the tumor expression of the protein could be important to identify those patients who are at risk of not responding to the treatment. So a cooperation of the genetic, germline, and somatic profile could be more effective in highlighting risky patients. And so we performed in a subset of patients also an immunohistochemistry analysis of the expression of SMAD3 protein. And we observed that SMAD3 protein expression at the tumor level is highly predictive, again, of the risk not to respond to a treatment, so to have a pure response to the chemoradiotherapy treatment. And when we add the information about the polymorphism previously highlighted, we were able to increase the odds ratio. So we were able to have a higher predictive value on the outcome of the patient. So this is the first evidence that probably we should work towards an integration of different kind of information in tumor and in the germline profile. So we went another step further, and we tried to understand what was the role of a somatic mutation. So we looked at the germline mutation, at immunohistochemistry expression of proteins, and then we moved to the somatic variants in genes related to the tumor response to chemoradiotherapy. So we applied a commercial panel of 71 colorectal cancer-related genes in the same subset of patients that was characterized for the other variants. And we, as a proof of concept in the first place, verify the role of KRAS and BRAF mutation in the risk of a poor response to the treatment. So you can see from this histogram that patients with the mutations had a higher risk of not responding to the treatment. And when we look at the disease-free survival of those patients, we observed that it was still significantly lower in patients that were carrier of RAS-RAF mutation. This is quite expected, but we notice also that also RAS-RAF pathway are downstream effectors of TGF-beta, so probably integrated the information of KRAS-RAF and also SMAD could maybe improve the prediction of poor outcome patients. And that was the case, in fact, when we added the patients that have concomitant SMAD4 in that case, because we are just doing preliminary analysis and we didn't have so many SMAD3 somatic mutations in these patients, but we are now enlarging the population set of cases, so hopefully we will be able to integrate also for all the SMAD factors the effect of the proteins. We had some patients with SMAD4, and we noticed that patients that had the combination of RAS-RAF and SMAD4 mutation had a very poor outcome, not only in terms of prognosis, but also in terms of tumor response. So it is we could also hypothesize that this kind of interaction could be related to a combined impairment of the downstream stimulation of TGF-beta related to the delivery of chemoradiotherapy. And this is the validation, I mean, not the validation, but we also had a look to the effect of this combination of variants on the pathological tumor response. So the combination of variants not only decreased the expectation of a disease-free survival, but also the likelihood to receive a complete response to the treatment. So it is likely that these kind of variants could be used in the selection of patients at risk of toxicity. If you are interested in having more detail on this project, don't miss the oral communication of Noemi, that is doing a PhD project on this stuff, and will give an oral communication on Thursday. And I think that the ultimate step here is the integration of all of this information. We are talking about germline profiling, somatic profiling in terms of expression, protein, and somatic mutations. So just machine learning approach and deep learning approach should be used to integrate all of this information in an algorithm that could be hopefully integrated in the clinical practice. We already performed some preliminary analysis in this sense, not in rectal cancer patients, but in colorectal cancer patients treated with fluoropyrimidine in association with irinotecan. And we were able to develop a score integrating genetic variants and clinical variants that could define additional features that can maybe overlooked without the use of this very powerful tool. I would like just to conclude my talk, just showing you that we were granted earlier this year by the Italian Ministry of Health to perform this very large project. So we will analyze a large set of locally advanced rectal cancer patients in our institute for germline profiling, tumor profiling, both in terms of mutation and RNA-seq. And we aim to perform a score based on on machine learning, and we want to validate it in this prospective study that is already set up. It is called Bridge 2, and it is a phase 2 clinical trial that will start very soon in our center. So to conclude my talk, I would say that there is room for improvement of efficacy of LARC patients using pharmacogenomic markers. But of course, the complexity of the tumor response phenotype required the integration of multiparametric information. And TGF-beta that is a pathway triggered by chemoradiation therapy could be a promising target for research of new markers. And there is, of course, a strong demand for powerful new machine learning in order to integrate those multiparametric information. And at the end of the day, the prospective interventional clinical trial could be probably the ideal context then to validate this kind of algorithm. So let me just conclude by thanking all my group, the group of experimental and clinical pharmacology unit in Aviano, and my director and my pharmacogenetic people, the group that is working with me to this kind of activity, and all the other colleagues, and all of you for your attention. I'm very happy to take any question.
Thanks a lot, Erika, for this splendid work. There is already one question. Please use this microphone to the left or the right and identify yourself.
Thank you very much. I'm Hervé Lelouet, Science President. Thank you very much for your crystal clear and really very interesting presentation. I have just one remark and perhaps one or two questions on the first part of your presentation. First of all, when you consider the drug safety and the side effect, the lack of efficacy is a part of the side effect. So you decided to share, which is logical because you focus after more on the toxicity of the drug rather than the efficacy. But finally, would it be more interesting to focus on the lack of efficacy, which is economically more a burden? Second thing is that you mentioned tolerable toxicity. Is it tolerable for the patient, or is it tolerable for the, not for the physician, with able finally to continue whatever the comfort of the patient? So thank you very much. Other question, you talk about the interest, and you show very clearly that there is an interest to make the genotype if you compare to the cost of the side effect. But the problem is that in low and middle income country, you can't do so easily a genotype. So supporting your idea, have you got any pharmacoepidemiologic studies showing a part of cluster of mutation in each part of the world, or is it only Italian and European focused?
Okay, I hope I will remember all the questions. So as concerning to efficacy, I agree with all the 3 points that you raised, that are all 3 very important indeed. And concerning the efficacy, yes, I completely agree. It's not easy to detect a signal of efficacy in this kind of studies because they are usually underpowered to see an effect on efficacy. And especially because if you want to look at efficacy, you have to look at very homogeneous classes of patients. But I hopefully will have some data also on the patients that I presented on locally advanced rectal cancer, because as I show you, we have a very large cohort of very homogeneous patients treated with the same, exactly the same regimen. So hopefully we will try to highlight also the effect on efficacy of the pharmacogenetic guidelines that we are now applying just to save toxicities. Related to the mild toxicity, I perfectly agree with you, but if you go to the clinicians and you say, okay, I can save a grade 2 toxicity, grade 2 neutropenia, they will say, okay, I don't completely care about that because we are dealing with cancer patients, so they consider very tolerable the toxicity as compared to the beneficial effect that the patients could have. But when you talk to the patients, they are very much concerned also about light toxicities, mild toxicity, and we noticed it especially with the UPGX project, in which we interact directly, interviewing many patients that were enrolled in the study and that can have their pharmacogenetic profiling in advance to the treatment, and they were very much interested in having the possibility to prevent their toxicity, much more interested than the clinicians. Regarding ethnic-specific variants and low-income countries, this is a very good point. We don't have, unfortunately, any data on patients of different ethnicity. And even if you look in the literature, it's very difficult to find data from other countries because 85%, I've read in a recent paper that 85% of genomic studies are based on European ethnicity, and this is the same for the pharmacogenetic guidelines. So I think that there is a lot of room for improvement in this sense, but I don't have any data to report today. I'm sorry.
Thank you very much, and very nice job.
You're welcome. Thank you very much.
One further question regarding also DPYD. You mentioned that only some proportion of the DPD activity can be predicted so far, 76% or so.
Yeah.
Could there be also genetic variants in regulatory genes not located in DPD?
Yeah, this is a very good point, because we are also, I mean, yes, regulatory genes could be important. We are also analyzing, I showed the NGS analysis that was focused on DPYD, but in the same panel we also included many nuclear receptors that could regulate the expression of DPYD. So those data that I showed you were produced by the Karolinska Institute, so I can't go too much in detail into the algorithm and the prediction that they did, but it is very likely that a nuclear receptor and other regulators could play an impact. So in the second step of our analysis, we will look also to the other effectors of expression and activity of the gene, of sure. Thank you very much.
Okay, thank you. I don't see any further questions. Thank you very much again.
Thank you.
We are coming now to our second talk. It will be given by Dr. Xiaocong from Beijing. She is a scientist who is, in particular, working on clinical pharmacology, innovative drug development, and early evaluation, with this particular interest in resistance and prostate cancer. And we are now going, we stay with in solid cancer, but maybe we are now going in some further aspects of regulation. So I'm looking forward to your talk, SPP1 mediated drug resistance and targeted intervention in castration-resistant prostate cancer with anti-androgen therapy. Please.
Thanks, Professor Ingolf's introduction. Good afternoon, everyone. I'm Xiaocong from Peking University First Hospital. My subject today is about the mechanism of SP1 alpha V beta 3 excess mediated enzalutamide resistance in castration-resistant prostate cancer and therapeutic strategy. Prostate cancer is the most malignancy and the second leading cause of death in males. And prostate cancer is an androgen-driven disease. And androgen deprivation therapy is the first-line treatment for advanced prostate cancer. Most people initially respond to ADT, but they gradually development from hormone-sensitive prostate cancer (HSPC) to castration-resistant prostate cancer (CRPC). And the CRPC is an invasive phenotype with a high potential for metastasis, especially metastasis to bone. Bone is the most frequently site for metastasis with up to 90%. Androgen receptor related resistance is considered as an internal cause. It includes androgen receptor abnormal activation. Actually, many drugs targeting androgen receptor, such as enzalutamide. So androgen receptor plays a critical role in for survival and development of most CRPC. But recently, it's reported the interaction of extracellular matrix with its receptor promote tumor cells, metastasis, and drug resistance. So targeting ECM could be a potential therapeutic approach for mCRPC. In my previous study, I cooperated with Professor Qian from University of Edinburgh, and we published a paper in JAMA. We found ECM receptor gene expression are significantly increased in bone metastasis compared with primary tumor and soft tissue metastasis. It is associated with anti-androgen resistance and poor survival. So in our further study, we investigated ECM genes profiles of HSPC and mCRPC, and we integrate 3 different benchmark databases. Through the machine learning methods, you can see this method. We identified 6 ECM genes, include SP1 and F11 and so on. And in this figure, we can see SP1 is the herb genes in the network. So we validated the 6 ECM genes in patient-derived organized models. SP1 mRNA expression was also most significantly deregulated among the 6 signatures. And SP1 expression varied in different data sets. We can see in the ball is highest. And based on the GSE result, we can also say SP1 could regulate the androgen receptor signals. And in our further study, we do IHC, we found SP1 high expressed in mCRC organoid. SP1, also known as OPN, is an integrally binding glycophosphoprotein. High expressed of SP1 correlated to poor prognosis and shortened survival in patients with advanced prostate cancer. We can say SP1 is high expressed in PC3 and DU145 and 22RA1 is androgen independent and metastasis prostate cancer cell line and is upregulated following enzalutamide resistance occurrence in vivo. And we also do IHC in the tissues. We can see SP1 is high expressed in bone metastasis prostate cancer. So we knock down SP1 to test its effects. We can say after knockdown, enzalutamide get more sensitive to in this model, and it can enhance enzalutamide resistance, inhibit cell proliferation, and apoptosis. The next test is downregulated pathway. It can inhibit PS3K AKT AR pathway and promote AR expression in lncap cell line. We found the knockdown SP1 could decrease the adhesion and the migration of CRPC cell lines and downregulated EMT pathway and PAMK pathway. So blockage SP1 and its interaction with its receptor alpha V beta 3 could be a promising target for overcoming enzalutamide resistance. Actually, interactions between cell surface integrins and ECM components has been found to be responsible for intrinsic and acquired therapy resistance, which named as CAMDR. So alpha V beta 3 could be a promising target for overcoming drug resistance. Alpha V beta 3 abnormal expression is associated with prostate cancer oppressive phenotype development. So we targeting alpha V beta 3 to find a small molecules could inhibit its activity. Through virtual screening, SPR assays, and anti-tumor evaluation, we identified compound netting is a hit compound with a good affinity and blockage prostate cancer tumorigenesis. And in this picture, we can see compound netting and enzalutamide has a very good synergistic effect on inhibit 22R1 cell proliferation. And then we modified the structure of compound netting, and we found the compound netting line is show a better affinity with a KD value of 0.102 micromole. And the compound netting line significantly inhibits prostate cancer proliferation in dose-dependent manner and reduce adhesion and migration of PC3 cell lines, and also inhibit tumor organoid-induced angiogenesis assay. From this picture, we can see the compound of the compound 99 with alpha V beta 3 is did not depend on monogonist-induced combination changes. So compound 99 is a pure antagonist of alpha V beta 3. And also, in the presence of monogonist, SP1 could interact with alpha V beta 3, but it can be blocked by compound 99. So in our further study, we use molecular dynamic simulation to search for the stable complex structure of compound 99 with integrate alpha V beta 3. And we found this one, tyrosine 122, is the key residues in the interaction. The hydrogen pi interaction can block beta chain to move into the medial side. So it's further provide compound 99 could pure antagonist of alpha V beta 3. And then we compared with enzalutamide in the vivo study. We can see in this dose 3 milligram per kilogram, and it can decrease tumor weight significantly, and especially in the CHRM-C1 models, compound 99 can decrease the tumor weight with 85%. So it's significantly better than enzalutamide. And also, compound 99 also has a very good safety. It didn't influence on the tumor weight, and it doesn't hurt liver, lung, and kidney. So we investigated the mechanism of compound 99 inhibitor of CRPC development. We do the RSeq study, and we found compound 99 can inhibit EMT and PI3K AKT-AR pathways, and also decrease the secret of VEGF-A and downregulated ERK pathway. And we also found compound 99 can inhibit JAK status 3 and IDO pathway. We know this pathway is associated with suppressive microenvironment. So compound 99 has different functions in CRPC development. So conclude, compound 99 is a very novel and no RGD inhibitor of alpha beta 3, and with excellent drug-like characters that could overcome enzalutamide resistance in CRPC. And it can supervise the development of CRPC by different ways, include PI3K AKT-AR, ERK, VEGF-A, and JAK status 3 IDO pathways. And we publish our paper in STT journal. In our first study, we invited by STT editor in chief, and we published a review about integrin. Actually, integrin has been investigated for 40 years, but only 7 drugs targeting integrins has been approved. A serious lesson from the past study is that the success on targeting integrins is rely on a deep understanding of integrin regulatory mechanism and unmet clinical needs. So this review describes all integrin families members and integrin-mediated downregulated signal translation transduction to inhibit ongoing study to development new therapy diagnosis from bench to clinical. Thanks to my Professor Cui and my team, and thanks to my cooperator, Professor Qian, and thanks for IUFA, and thanks to all of you. Thanks for your attention.
Thank you very much, excellent. And I'm impressed what has been done in the last 2 years, additionally to the time where we proposed the symposium. So
yes.
Really congratulations.
Yeah.
So are there any questions, Dr. Pang? Again, Avi? Please use the microphone because we record the session.
Thank you very much. Very nice presentation. Just a small question about the incidence of the prostate cancer in men. Is it so important? Because I was the feeling that it was a lung cancer were the previous one. Because you mentioned 27. Is it in a specific area of the planet or it is everywhere? The first slide you mentioned. 27% or something like that. Not, yes, this data, the estimated new cases. The population
you
source.
mean this?
Sorry?
You mean this?
Yes.
Yeah. Yes, so it's a leading cause of death in males.
No, I know, but this study has been made worldwide or only in some party of the...
worldwide.
Sorry?
You mean prostate cancer happened in...
Is it the same proportion in Europe, in China, in Japan, in Africa?
Oh, yes. I think it's from America because the data is from cancer statistics. Yes.
Okay, because the exposition to the epigenetic factors are not the same according to the population.
Yes.
So.
Yeah,
okay,
yes.
Thank you.
So we move now to the next speaker.
Thank you.
Thank you. Yeah, sorry. Thank you. So I don't know if Dr. Hamd Misbah is present in the room today. No. So okay. So we can move to the next speaker. That is Dr. Meike Kaehler, and it's my pleasure to introduce her. She's working in the group of Professor Cascorbi as a young researcher. She works in the University Hospital of Schleswig-Holstein campus Kiel, and she's an early career scientist, and she's primarily working on molecular mechanism of drug resistance of tyrosine kinase inhibitors in CML, including interaction of transporters with microRNAs, DNA methylation, clonal expansion of somatic novel mutations. So we were looking forward for your presentation, and the floor is yours.
Thank you for the kind introduction, and I would also like to thank the organizers for this opportunity to speak here. I really appreciate it. So as already mentioned, I want to talk about potential biomarkers in the therapy and also in the resistance in chronic myeloid leukemia. So first of all, I want to give you a brief overview about the disease I'm going to talk about. So chronic myeloid leukemia, or short CML, is a myeloproliferative disorder that is quite rare, but still makes up to 15 to 20% of adult leukemia. It leads to massive accumulation of mature and later on also immature granulocytes, leading to the symptoms depicted here. CML usually progresses in 3 phases. The first phase is a chronic phase, which lasts for a couple of years, and this phase is usually asymptomatic. That means the diagnosis of CML usually happens by hazard during routine checkups. If untreated, CML then eventually progresses in an accelerated phase and then eventually in a blast crisis, which is visible by more than 30% blast in the blood, and this phase is lethal if untreated. On the molecular level, CML is very well defined. It is predominantly caused by reciprocal translocation of the Q arms of chromosome 9 and 22, leading to formation of the so-called Philadelphia chromosome, which basically is a shortened chromosome 22. And on this chromosome, on this Philadelphia chromosome, a fusion gene emerges, the so-called BCR-ABL1 fusion gene. Thereby, one part of the protein, BCR, encodes the breakpoint cluster region gene. This is a protein, a phosphoprotein with widely unknown function. And the other part of the protein is the Abelson kinase, the ABL gene, and this encodes a cytosolic tyrosine kinase, which is very important for the cell. The presence of this fusion gene leads to deregulation of several pathways, as you can see here. So it leads to sustained proliferative signaling via RAS-MAP signaling and JAD-STAT signaling. It leads to anti-apoptotic signaling mediated mostly via ACT. And also it leads to increased motility and alterations in cell adhesion. So the presence of this fusion gene is the hallmark of the disease, and it leads to malignant progression of the cells. So since 2001, CML can be effectively treated using so-called tyrosine kinase inhibitors, or short TKIs. So in CML, ATP is able to bind to the kinase domain and BCR-ABL1, which leads to downstream target phosphorylation and the changes in the signaling pathways, as I've just shown. The tyrosine kinase inhibitors are mainly designed in that way to bind to the kinase domain, which prevents the downstream target phosphorylation and thereby inhibits the signaling alterations that I've just shown. So it mainly has a cytostatic effect, but eventually also leads to cell death. So the first question is, when we think of biomarkers, what is the biomarker here? Actually, that's a quite easy question. Who can benefit from such a treatment? Basically, every patient who suffers from a BCR-ABL positive tumor can be treated with these kind of tyrosine kinase inhibitors. This is mainly CML, but also some rare cases of Philadelphia chromosome positive ALL. The use of imatinib in CML has been tremendously successful, as you can see here. So imatinib was way superior than all the other treatments that have been there before, and it immediately became first-line therapy. And the use of imatinib in CML has shown for the first time that kinases can be used as druggable targets, and it was the role model for the whole plethora of TKIs we now use in anti-cancer treatment. For CML, there are meanwhile 6 TKIs on the market. So as I said, first generation imatinib, second generation nilotinib, dasatinib, bosutinib, and in third generation we have ponatinib and asciminib. These all differ in their potency, efficacy, in the mutation spectra. I will come back to that a little bit later, and they also differ in their side effects. So I've just told you that the TKIs bind to BCR-ABL1, which leads to the prevention of downstream target phosphorylation, and this has a cytostatic effect. So this would mean that when we discontinue the treatment and there's still some residual tumor cells, ATP is again able to bind to those tumor cells, and we have the same signaling as in CML again, so sustained proliferative signaling. That means so far that the use of TKIs in CML is a lifelong therapy. But the question is that really true? There's a huge variety in studies dealing with this issue, and here in a recent review, 14 of these studies were summarized, including more than 2,000 patients. And you can see here that the recurrence-free survival after TKI discontinuation was really variable between 38 and 64%. So some studies look more favorable than others. So here I want to show you 2 examples of these studies. This is one from Etienne, dealing with imatinib discontinuation. And you can see here that within 6 months after TKI discontinuation, more than 50% of CML patients suffer from a relapse. In another study, here dealing with dasatinib discontinuation, You can see the treatment-free survival here, so that's why the graph looks the opposite. But still, we see mainly the same picture. Within 6 to 12 months, more than 50% of the patients have relapses. So basically, this is 50-50, and this is almost like flipping a coin, so this is not sufficient for what we need for the patients. So are there any biomarkers we can use to predict if a patient will be safely able to discontinue the TKI treatment or not? And again, this is widely discussed. So here I summarized the main markers that are discussed so far. So first of all, only patients in the chronic phase prior to the treatment should be considered and not in advanced phases. Then the BCR-ABL transcript seems to influence the treatment outcome after discontinuation. I don't want to dive into that any deeper. The main prognostic factor we have seems to be the therapy duration. So the therapy should have last at least 5 years with a so-called deep molecular response for more than 2 to 3 years. That means that the transcript ratio from BCR-ABL1 should be below 10 to the power of -4 or 10 to the power of -5. So at very, very low level for 2 to 3 years. So then it might be an option to discontinue the treatment, but still, as I said, it's more like 50-50, so I think we definitely need more studies on that. The use of TKIs in CML has been tremendously successful. For imatinib, we have an overall survival rate of 83%. But still, 20 to 25% of our patients need alternatives to their TKI treatment within already 5 years of treatment after therapy begin. And there are 2 big options why those patients become resistant. So one depicted here on the right side are so-called BCR-ABL dependent mechanisms. So this goes back to changes and alterations in the BCR-ABL kinase, mainly overexpression or also point mutations. This is about 50% of the cases. For the other half, so-called BCR-ABL1 independent mechanisms are discussed. And here we have a huge variety of potential mechanisms. So one is deregulation of drug importers and also drug efflux transporters. Another one is so-called alternative signaling to circumvent the BCR-ABL kinase, and also quiescence of our tumor cells and the presence of leukemic stem cells are discussed. And I want to give you some more information about that. So let's first have a look at BCR-ABL mutations. As I said, 50% of the cases. And you can see on this table here that for every single TKI there is a mutation described that at least leads to partial or full resistance against the TKI. And you can see here in bold and here in blue, this is the main culprit we have. This is the so-called gatekeeper mutation, the exchange of 309 on position 315 to isoleucine. And this mutation leads to loss of efficacy for first and second generation TKIs, as you can see here. So the only option we have are third generation TKIs, so ponatinib and asciminib. And maybe you wonder, why are these still effective while the others are not? So the first and second generation TKIs require an amine group and a hydrogen bond to this 315 residue in order to sufficiently bind to the BCR-ABL kinase. Ponatinib does not have this amine group. It has a triple bond, so it does not need this hydrogen bond anymore. So it is able to fit into the kinase pocket. Still, we need to increase the dosage here. And asciminib, this is the latest TKI there is on the market. This binds independently from the kinase domain because it is an allosteric inhibitor. It binds N-terminally to the BCR-ABL kinase, and therefore it is able to still act while the others are not. And this was also the main purpose why it was designed. So regarding biomarkers, what do we do here? Of course, we have to look for BCR-ABL1 mutations in our patients and then decide which TKI to use. And if there are any mutations, we have to switch. In general, if we want to analyze therapy resistances, in vitro models can be very pivotal and very useful. So you can obtain them by, in our case, using a CML cell line, a BCL positive cell line, and administer a low concentration of your drug, so in our case, a TKI. And then you wait until the cellular proliferation rate is restored. And then slowly and stepwise, you increase the concentration. So you end up with cells that are resistant to a given dosage of your drug. So in our lab, we performed this whole procedure, but not only once, but we established biological replicates. So we had 4 different replicates, so like 4 different patient cell lines, so to say, for imatinib, and also 2 for nilotinib, and also meanwhile for other TKIs. And their resistance against different dosages for the TKIs. So the first thing we did with this model was to look into ABC transporters. And as you know, ABC transporters are membrane proteins that facilitate the outward-directed transport of endogenous substances, but also of xenobiotics, such as chemotherapeutics, among them also tyrosine kinase inhibitors. So we analyzed the expression profile of ABC transporters, and we found that there was one, namely ABCG2, so the breast cancer resistance protein, that had a quite interesting expression pattern. So you can see here that we have a high upregulation and a high expression of ABCG2 on mRNA and also on protein level, but at quite low dosages of imatinib. And as this expression pattern was very interesting, we wondered how this is regulated. So as we wanted to focus on potential regulators, we looked into microRNAs, because these are regulators of post-transcriptional gene expression. And indeed, we found that there was one particular microRNA, namely microRNA 212, which showed the inverse pattern compared to ABCG2. So there was an inverse expression pattern of the microRNA 212 and ABCG2. And in addition, what I don't show here is that we were also able to show that the microRNA 212 is able to bind to the ABCG2 3' UTR. So this raised the question if this has any influence on imatinib susceptibility. To address this question, we transfected our cells with microRNA 212 inhibitors and then administered the TKIs to see if we have changes in the drug response. And you can see here we did this experiments for treatment-naive cells, so imatinib-sensitive cells, but also with the different cell lines from our in vitro model. And you can see here that cell viability was significantly increased and apoptosis significantly decreased, but only in treatment-naive cells, so cells that have never seen the TKI before. And this effect was lost when you look at the imatinib-resistant cells. So we performed some more experiments on that, and in the end, we were able to show that when we inhibit microRNA 212, or it is downregulated in imatinib resistance, we have an upregulation of ABCG2, which leads to a higher level of ABCG2 on the cell surface, and then more efflux of imatinib, so diminished cell death, and this likely contributes to the resistance we observed in our model. In the next step, we performed an unbiased approach. So we had a look at genome-wide expression changes in our biological replicates. And what you can see here on this heat map, and I hope you agree, is that there was quite some variation between the different biological replicate cell lines, so for imatinib, for nilotinib, and also the replicates. But we wanted to address the question if there are any recurrent changes in TKI resistance, so we focused on that. And you can see here that when you look into the gene expression, you see that the focal adhesion was significantly decreased or altered, let's say, in all replicates, independent from the TKI and independent from the dosing. And the gene that had the highest fold chain here was fibronectin 1. So fibronectin 1 was significantly downregulated in TKI resistance recurrently. And we've just seen that fibronectin 1 is part of the extracellular matrix, and it is involved in this cell adhesion-mediated drug resistance. And this came as quite a surprise to us because fibronectin 1 is known for its role in solid tumors, as we've just seen. But here we are in the context of a leukemia. So we wanted to address this question a little bit further and elucidate that. So what we did first was to perform siRNA mediated knockdown of fibronectin-1 expression. And after successful knockdown, we analyzed the cell fitness under TKI exposure. And you can see here that when you knock down fibronectin-1 compared to the control, you see a significant increase in the cell number and also in the proliferation for all TKIs that are on the market so far. So you see this effect for imatinib first generation, you see this for all the TKIs in the second generation, you also see this for ponatinib and also for the novel STAMP inhibitor, asciminib. So the fibronectin-1 knockdown reduces the response to all approved TKIs. So in a vice versa experiment, we used our resistant cell lines and restored the expression of fibronectin-1, which was downregulated initially. So first we did this for imatinib, and again we transfected the cells, in this case with a plasmid encoding fibronectin-1. And after successful knockdown, we analyzed cell adhesion and also the cell fitness. You can see here that in the 2 replicate cell lines we used here, cell adhesion was significantly increased in both replicates after transfection of fibronectin-1, while the cell number was significantly decreased as well as proliferation. So we were able to at least partially restore imatinib susceptibility, so partially overcome TKI resistance. And we were able to show this not only for imatinib, but also for nilotinib and dasatinib so far. Well, of course, this is in vitro data, and the big question is, how does this look in vivo? So we performed a small study, including 11 CML patients, and analyzed the fibronectin-1 expression in the samples from diagnosis, but also in follow-up samples, meaning within the course of the therapy. And what you can see is really interesting. So if you look here, you see the patient had imatinib therapy and quite a high level of fibronectin-1, and the patient was in molecular remission. Then the TKI had to be switched due to compliance issues, and you see that the molecular response is lost, so we have a relapse, and you see here that fibronectin-1 expression was reduced. So then the TKI was switched again to dasatinib, and again we had a full remission here, and fibronectin-1 expression was increased again. And if you look at all patients together, you see that patients that had no molecular remission, so were resistant, had a lower expression of fibronectin-1 compared to those that were responding. And of course, this nicely fits to our in vitro data because it basically shows the same. When you think back of the heat map I just presented and remember that we had these huge differences in the expression profile, you might also wonder why this was the case, and this is what we were wondering as well. And to address this question, we thought that maybe genetic aberrations might play a role, so we had a look at mutations. So we took the cells of our in vitro model and performed exome sequencing. And in 4 out of 6 biological replicate cell lines, we were able to identify mutations that are likely to explain why the cells are resistant. And some of the culprits we find here, we've already heard about. So for example, in this cell line here, nilotinib-resistant cell line, 1 replicate, we found a mutation in NRAS, namely NRAS Q61K. We already have seen this on the slides. This is one of the hotspot mutations in NRAS. And in another cell line, in imatinib resistance, we found that there was the KRAS G12D mutation, which is another hotspot of RAS. In the same cell line, we also concomitantly found a mutation in ABL, and this is a mutation that also is known to at least partially provide imatinib resistance. But further in other cell lines, we found other candidate driver variants that were not known previously. So what we did then was to establish an analysis pipeline to analyze those variants with unknown effects. So of course, we first initially used one variant with a quite clear effect, which was NRAS Q61K. So when we transfected the cells either with the NRAS wild type or with the mutation, we then performed cell fitness analysis. So we analyzed the cell number, and you can see here that this was significantly increased for the wild type and also for the variant. We analyzed metabolic activity, also apoptosis, and what we observe here was quite clear because we assumed that this variant has an effect and is likely to promote resistance. We then focused on another variant, namely PTPN11Y279C. And PTPN11 is associated with some kind of juvenile leukemia, but mainly its deregulation. And the variant we observe here was previously known with hereditary diseases such as Noonan syndrome or Leopard syndrome. And these are diseases that lead to mainly neurological deficits and also to heart issues. So it was not associated with cancer yet. So we used our pipeline then and also transfected those variants. And you can see here that the presence of the variant provides benefits for the cell. So the cell number was significantly increased, and also metabolic activity and proliferation was significantly increased. So it is likely that this replicate that harbors this mutation is resistant due to the presence of this mutation. And this was a study we just very recently published. So in summary, I've shown you that in CML therapy, of course, we need BCR-ABL1 expression. This is prerequisite for TKI treatment. When we think about discontinuation of our TKI treatment, still we have to say that only a proportion of CML patients will be able to safely discontinue the treatment, and still it's rather risky, it's 50-50, so we need better biomarkers here. Regarding TKI resistance, I've shown you that especially this gatekeeper mutation 315I is the main culprit here and also the main driver for the development of new BCR-ABL inhibitors. But beyond mutations, I've shown you that ABC transporters might play a role. I've shown you the regulation of ABCG2 via the microRNA 212. And then I've shown you that cell adhesion signaling is involved in leukemia and not only in solid tumors, obviously. So we've seen that fibronectin-1 expression might be not only a biomarker, but maybe potentially, after future studies, also target in TKI resistance. And then we saw that in TKI-resistant cell lines, but likely also in patients, we have mutations in other potential driver variants or mutations that are already known, such as NRAS, KRAS, or also PTPN11. So we believe that it would be beneficial for TKI patients that are resistant to the treatment to screen them for candidate driver gene expression, but also mutations, because maybe this facilitates the treatment of another TKI that could be concomitantly used. So with this, I would like to conclude. I would like to thank the whole group in our institute for their support and help in all of my projects. And I would also like to thank all of our cooperation partners from the different facilities in Kiel and Lübeck and Ulm and also in Poznan, and of course you for your kind attention.
Thank you very much, Meike, for the excellent presentation and excellent results indeed. So the presentation is now open for discussion. Is there any question? Please go ahead. Yeah.
Thank you very much. A really nice job. I have 3 questions, but not very complicated. When you say we stop the treatment and there is a risk of relapse, is it relapse on the same way, meaning chronic, or you have a higher risk of blast crisis?
So initially it is a chronic phase, but you never know if it's a clone that will be resistant to the treatment or if it's a clone that will be susceptible to the TKI treatment. So that's, I think, the main issue here. You never know. In most cases, luckily, the patients still respond to TKIs, but still, as I said, you never know.
Okay. So the second treatment, considering all the mutation and according to the new generation of TKI, what is your therapeutic recommendation? Should we start with the 3rd generation immediately or have a graduated approach?
So no, I would not start with a 3rd generation TKI because they also have more side effects. So in the guidelines, it says we should start with imatinib or with nilotinib and then go from there. But of course, if there are already mutations there, then we have to take the other ones. But For example, dasatinib has way more severe side effects regarding pleural effusion, for example, and also ponatinib has more side effects, also because the potency is higher. So I would stick to that and say start with imatinib and nilotinib if possible, and then see and go from there.
And finally, last question. You know, like me, that TKI is not only for LMC. So do you have an idea if this type of mutation can arise in different indications that myeloid?
You mean from our exome sequencing? Yeah, I believe they're independent from the TKI. They could derive. It's just, it shows that in the CML model we have a high oncogene addiction. So that means if we're able to circumvent BCR-ABL1 via RAS, for example, or via any other target gene, then this drives the clonal selection and evolution, and I think that's a common phenomenon for other types of targeted therapy as well. Yeah.
Okay, so thank you very much.
Welcome.
Thank you very much for this excellent talk and overview and the excellent data. I have only one question. You showed up plenty of different biomarkers should be considered for CML. Do you believe that makes sense to establish an algorithm to consider all these different biomarkers and to find a way, like polygenic risk score is not only genetic, but polybiomarker risk or whatever, to improve therapy in the future for patients with CML?
Oh, that's an excellent question. So I think the first thing, I mean, that's already done, is you need to know that there is BCR-ABL1 expression. Yeah. That's prerequisite. But I think then if there is a patient that is resistant and you don't find any mutations in BCR-ABL1, I think those patients would highly benefit from such a panel. Okay. Yeah, I think that would be a good idea in the future.
I have a small question. Is there? Oh, sorry, please.
Very excellent job. I know in many cancer types, FN1 promotes drug resistance, but in your study, FN1 low express. Yeah. Yes. So, what's potential mechanism do you think?
Yeah, this was very surprising to us as well, because if you look in the literature, then you have the impression that what we see in leukemia is the totally opposite to all the other tumors. But if you distinguish between solid tumors and leukemia, and assume that it is a cancer-dependent effect, so like dependent on the type of the tumor, then I think it makes sense that we have differences here. So it is known, for example, that when you treat the patients with TKIs, then you have reduced cell adhesion. So it makes sense that that something changes here, and you see the opposite. So, yeah, I don't have a full explanation for that, but I think it just simply depends on the cancer type, so the entity.
Okay, thank you.
You're welcome.
Any other question? So I just would like to ask you about, we know that the TKI are affected by a dramatic inter-individual variability in terms of exposure, plasmatic exposure, and for imatinib, for instance, we also have clinical guidelines for dosing by TDM, the drug. So do you think that those biomarkers that you showed could be have different significance in different exposure context, or if connected with the TDM data?
Yeah, I think the patients would benefit from that, but as far as I'm concerned, it's not done yet. So you just simply go for BCR-ABL, expression and then mutation, and then it's almost like you just skip the use of the TKI. You just switch. If it doesn't work, you use another one. So it's not really like guided. So I think that would be good if we could do that, in the future.
So thank you again, Meike, for the very nice presentation. Okay, so we move to the final presentation of the session. So I call Professor Xiaocong to the podium. Professor Xiaocong is working at the Sichuan University in Chengdu in China, and is one of the pioneers in the long non-coding RNA study. He has been committed to studying the interaction between long coding RNA and protein and the significance of this interaction in tumorigenesis. So he will present his data.
Okay, thank you for the introduction. I will share with you some of my work on tumor-associated lncRNA. In mammals, most of genomic sequences are used to transcribe the lncRNA. And the human genome can encode only around 20,000 proteins, and it uses only 2.94% of genomic sequences. 72% of genomic sequences are used to transcribe lncRNA. The human genome can be transcribed more than 200,000 lncRNA. lncRNA can exert their functions by interacting with proteins, DNA, or RNA. lncRNA can regulate gene expression at multiple levels and play an important role in various physiologic and pathologic processes. Okay. lncRNA can regulate DNA replication, RNA transcription, and protein translation. And the lncRNA are involved in the regulation of any steps of gene expression. And both nucleus and mitochondria can encode lncRNA. Okay, my presentation has two topics. I will talk about the implication of nuclear lncRNA and the mitochondrial lncRNA in cancer biology. The first is the role of chromatin-tethered MOT1 in modulating alternative splicing in liver cancer. And the second one is the mitochondrial lncRNA MD1 mediates mitochondrial to nucleus retrograde regulation by inhibiting the nuclear translocation of p53. Understanding how lncRNA cooperate with splicing factor in the control of alternative splicing is crucial for human biology and disease. MOT1 RNA is primarily localized to nuclear speckles. MOT1 was proposed to regulate alternative splicing by modulating the activation status of SR protein and by facilitating SR protein shuttling between speckles and the sites of transcription. It's already been reported that MOT1 also targets its actively transcribed genomes and interact with many nascent pre-mRNA, but it doesn't know the implication of the chromatin-tethered ring or pre-mRNA targeting MOT1 in gene expression. Okay, the RNA-binding protein PDBP1 are well-characterized RNA-binding protein. It is consistently co-purified with PSF protein. Work by us and others has shown that MOT1 is a direct RNA target of PDBP1 and PSF. We wondered whether there was a molecular link between these three molecules. The co-IP analysis showed that PDBP1 and PSF interact with each other in an RNA-dependent manner. We carried out co-IP analysis with or without MOT1 knockdown. MOT1 knockdown has no effect on PDBP1 and PSF protein level, but it resulted in a substantial decrease in the PDBP1 and PSF interaction. Co-localization of MOT1, PDBP1, and PSF was reviewed using in situ hybridization and immunofluorescence staining. PDBP1 and PSF are diffusely distributed throughout the cell nucleus, but exhibit a speck-like distribution pattern after MOT1 knockdown, suggesting that MOT1 influences subnuclear localization of the two splicing factors. Thus, MOT1 may maintain the PDBP1-PSF interaction. We carried out a co-IP-ANC after knocking down MOT1, PDBP1, PSF interaction was inhibited. A work expression of MOT1 can increase the PDBP1 PSF interaction weakened by MONET1 knockdown. Because both PDBP1 and PSF can act as splicing factor, they identified MONET1 stabilized PDBP1 PSF interaction with a possibility that MONET1 may participate in regulation of pre-mRNA alternative splicing while bound to PDBP1 and PSF. We analyzed the PDBP1, PSF, and MONET1 mediated alternative splicing regulation using RNA-seq. MONET1, PDBP1, and PSF were found to affect different types of alternative splicing events. We first analyzed the most represented categories. The cassette exons, a total of 156 exons, was reviewed to undergo a cooperative regulation by MONET1, PDBP1, and PSF. The alternative splicing regulation by MONET1, PDBP1, and PSF was also observed for other categories of alternative splicing events. We tested several tumor cell lines by co-IP analysis. The RNA-dependent PDBP1 PSF interaction was detected in all the tumor cell lines that we tested. The MONET1 stabilized PDBP1 PSF interaction was detected in all the tumor cells that we tested. RNA-scope in cytohybridization and immunofluorescence staining also verified the colonization of MONET1, PDBP1, and PSF, and the change distribution of PDBP1 and PSF by MONET1 knockdown in the nucleus of HepG2 cells. Thus, our data strongly suggests that MONET1 can stabilize PDBP1 PSF interaction in multiple cell lines. Given that MONET1, PDBP1, and PSF interact together to constitute a complex, they are assumed to act as a functional module if their expression levels maintain a proportional relationship in specific biological contexts. We extract expression data of MONET1, PDBP1, and PSF from the TCGA database and analyze the correlation of their expression levels for different types of human cancer. We found that expression levels of PDBP1 and PSF are positively correlated with each other in all cancer types. Notably, a positive correlation between expression levels of MONET1 and that of PDBP1 and PSF was revealed only for liver cancer. The observation suggests that although formation of a complex appears to be general biologic events for MONET1, PDBP1, and PSF, the complex might have more dominant biologic significance in liver cancer. We analyzed the expression levels of MONET1, PDBP1, and PSF in liver cancer samples from the TCGA database and the GO database. The results showed that tumor tissue samples exhibit a significant upregulation of MONET1, PDBP1, and PSF in this database. Disease-free survival data showed that the higher MONET1, PDBP1, and PSF was not statistically associated with clinical outcomes. An interesting finding is that when MONET1, PDBP1, and PSF are all expressed at a higher level, the patients have significantly reduced disease-free survival time compared with others. Survival curves were also drawn for breast cancer, lung cancer, and colon cancer, which exhibit no positive correlation between expression level of MONET1 and that of PDBP1 or PSF. We found that none of MONET1, PDBP1, and PSF was prognostic value in these cancer types. The prognostic value was not observed for their simultaneous high expression. Thus, our data associate expression levels of MONET1, PDBP1, and the PSF with liver cancer development and prognosis, and strongly suggests they may act as a functional module in liver cancer. We investigated whether MOT1 also cooperates with PDBP1 and PSF to regulate pre-mRNA alternative splicing in liver cancer cells. Among the MOT1 regulated exons, 258 were also regulated by PDBP1 and PSF, exhibiting a similar degree of overlap observed in 293 cells. We randomly select and confirmed some of the regulated exons. Using RT-PCR in HEP2 cells, the regulated exons were found to be substantially enriched in genes involved in various signaling pathways associated with other cancer types, suggesting a functional implication of the MOT1 PBP1 PSF interaction in development of liver cancer. We carried out a RIP-seq to identify PDBP1 and PSF binding sites on pre-mRNA. Both PDBP1 and PSF recognize the motifs containing pyrimidine-rich elements. By analysis of RNA-seq and RIP-seq data, 67 of these genes were found to be directly regulated. 10 of them were selected for RIP validation and their association with PDBP1 and PSF. Pull-down and chip assays also revealed that MOT1 interact with these genes. Using 2C analysis on HEP2 cells, we found that MOT1 knockdown leads to a substantial decrease in the level of RNA-associated PSF. In contrast, the association between PDBP1 and cellular RNA was not changed after MOT1 depletion. We analyzed the contribution of MOT1, PBP1, and PSF to the malignant property of liver cancer cells. Knockdown of MOT1, PBP1, and PSF in HEP2 cells significantly inhibited cell growth, migration, and invasion. Similar results were also shown in HCC-LM3 cells. HEP2 cells stably depleting MOT1, PBP1, and PSF or control cells or injected into node mice. Both the tumor value and weight showed a remarkable reduction in the target depletion groups compared with the control group, indicating that stable knockdown of MOT1, PBP1, and PSF effectively inhibited tumor growth in vivo. MOT1 overexpression has the ability to make a significant promotion in cell growth, migration, and invasion. The ability, however, was almost completely inhibited by PDBP1 PSF double depletion. We also explored whether MOT1 was a dominant contributor to regulator effect of PDBP1 and PSF. PDBP1 and PSF overexpression was revealed to promote cell growth, migration, invasion, and whereas MOT1 depletion significantly abolished the effect. In HCC-LM3 cells, we got the similar results. Our current study presents a model in which MOT1 cooperates with the splicing factor PDBP1 and PSF to form a functional module that directs PDBP1 and PSF associated with pre-mRNA and regulates a net of alternative splicing events, providing new insights into mechanism of MOT1 in the regulation of gene expression. The functional module consisting of MOT1, PBP1, PSF may have more pathogenic implication in liver cancer. And we conducted a set of RIP and co-IP experiments to test several HMP proteins other than PDBP1, including HMP-A1, HMP-F, HMP-U. For their binding to MOT1 and to PSF, results showed that all the HMP proteins can bind to MOT1 and that the MOT1 binding can facilitate their interaction with PSF. These findings suggest that MOT1 may play a broad role in alternative splicing regulation by coordinating the action of different splicing factors. Considering lncRNA and their binding partners comprehensively should provide more valuable information about their biological function than an analysis performed specifically only for lncRNA. And mitochondria are the only organelles in mammalian cells that have their own genetic material. Mitochondria encode only 13 proteins. Nevertheless, most of mitochondrial proteins are encoded by the nuclear genome. And most of the mitochondrial activities are run in nucleus-relying manner. Mitochondria also import some lncRNA transcribed by the nucleus. And some of the nuclear lncRNA appear to regulate mitochondrial network. However, similar to nucleus, mitochondria can transcribe lncRNA. Although a few of mitochondrial lncRNA have been shown nuclear localization, but their function are still don't know. It's becoming increasingly clear that bidirectional communication between nucleus and mitochondria is required for the maintenance of whole cell homeostasis. Interplay with protein is a well-characterized action model for lncRNA, and all related studies also showed that lncRNA can achieve their regulatory function by interacting with specific proteins and modulating their activities. P50 strain has long been characterized as an RNA-binding protein, but the significance of its RNA-binding property remains largely partly because of the failure to identify specific RNA partners that affect P50 strain function. To determine whether there is any lncRNA can affect P50 strain targets transcription by modulating P50 strain, we set out to identify P50 strain binding lncRNA from an RNA library using RNA-seq. Among the candidates, we are intrigued by a mitochondrial lncRNA MD1, which is transcribed from the D-loop region, which is the major non-coding region of the mitochondrial DNA. Okay, FASP21 and Kiel are strain well-characterized P50 strain targets, which acts as P50 strain downstream effectors to facilitate the P50 strain regulated cellular process, such as proliferation and invasion, as revealed by RT-PCR and Western blot. Expression level of these strain genes were decreased after MOT1 overexpression in P50 strain knockdown cells. However, the overexpressed MD1 could hardly exert any of the regulatory function. ChIP-RNA showed that overexpression of the MOT1 reduced the P50 strain occupancy on promoter region of these genes. Thus, our results provide support for a role of MD1 in controlling transcription regulation of P50 strain on target, and suggests that MD1 exerts its regulatory function in a P50 strain-dependent manner. We further provide the gene expression of A549 cells with a result MD1 knockdown by RNA-seq. We gain a comprehensive insight into the molecular function of MD1. To our surprise, the majority of the differentially expressed genes are nuclear genes, pointing to a significant implication of MD1 in regulation of nucleus expression. We analyze the functionality of MD1 in cells for A549 cells. Overexpression of MD1 promoted cell growth, survival, and migration. However, in P53 knockdown A549 cells, MD1 has no effect. So we propose that MD1 may act as a P53 regulator, while it's direct P53 binding. And then P53 is necessary and sufficient for the function of MD1. We carried out an RNA pull-down assay to identify MD1-associated proteins other than P53, the TAT1 protein, which was previously reported to form a complex with P53, was present only in the MD1-associated sample. To verify the result, we analyzed the unpulled-down protein samples by Western blot. We observed a specific binding signal for TAT1 in protein put down by MD1 RNA, but not in proteins associated with antisense RNA. Thus, we confirm that the enrichment of TAT1 in the MD1-associated complex. We tested the interaction between endogenous MD1 and TAT1 protein by RIP-RNA RT-qPCR analysis of the RIP products, detected MD1 only in the complex that was enriched by anti-TAT1 protein and TAT1 antibody. Thus, these results indicate that TAT1 is a MD1-associated protein. We provide the TAT1 regulated gene expression for the purpose of assessing the implication of TAT1 in the regulatory function of MD1. 971 genes were regulated by both MD1 and TAT1. KGG function notation of the 971 genes co-regulated by MD1 and TAT1 also identified the cell cycle control as a major functional cluster. We selected several overlapping genes that have been documented to function in cell cycle control and validated their expression change after MD1 and TAT1 knockdown by RT-qPCR and immunoblotting. Furthermore, we assessed the cell cycle distribution of A549 cells after MD1 or TAT1 knockdown. We found that all the knockdown experiments lead to an inhibition of the G1/S transition in cell cycle. Therefore, we propose that the TAT1 and the MD1 interaction control the cell cycle. The binding of MD1 to P53 and TAT1 suggests a molecular link among these three molecules. We use co-IP assays to detect the interaction between P53 and TAT1 in A549 cells. We observed that the P53 IP retrieved TAT1, and the TAT1 IP also retrieved the P53. However, the P53 TAT1 interaction was significantly weakened by an RSA treatment, suggesting that the interaction of P53 and TAT1 depends on RNA. We next carry out co-IP assays using A549 cells with or without MD1 knockdown, and the results showed that MD1 knockdown resulted in a significant decrease of P53 and TAT1 interaction. We analyzed the gene expression profile of MD1, TAT1, and P53, 266 genes co-regulated by the complex, and the KGG analysis is revealed a coordinated regulation of P53 signal transduction by MD1 and TAT1, as well as by the gene expression analysis that detected by an overlap of genes regulated by MD1, TAT1, and P53. Surprisingly, the top one of KGG terms of these genes is cell cycle, whereas the complex almost have no effect on apoptosis, although both TAT1 and P53 are associated with apoptosis. We explored whether certain biological feature of P53 is under control of MD1, P53, TAT1 complex. By immunofluorescence, detection MD1 knockdown was revealed to inhibit cytoplasmic localization of p53 and result in an accumulation of p53 in nucleus, exhibiting an effect on p53 distribution similar to TET1 depletion. Our results suggest that MD1 may act as an RNA scaffold that bind p53 and TET1 together, and that the complex may inhibit the nuclear translocation of p53. So given that p53 is a transcription factor, the inhibition of p53 nuclear translocation may decrease transcription of its target, suggests that MD1 mediates mitochondrial retrograde regulation of cell cycle related genes expression by inhibiting p53 nuclear translocation. Okay, thank you.
Thank you very much.
Okay.
Yeah, thank you. I have one question. Concerning these long-coding RNAs and other factors you presented to us, how can they nowadays already be considered as a biomarker in cancer therapy, for instance, in hepatocellular cancer?
Okay, I think lncRNA is a very useful biomarker, especially when we compare the expression level of different lncRNA in tumor tissue and the normal tissue. Sometimes the difference can be even several hundred-fold, sometimes even ways of result. So I think it's a really useful biomarker.
Okay, thank you.
You're
Yes?
welcome.
Thank you very much for this nice talk and overview. I have only one specific question. You mentioned that there may be a contribution to mitochondria. Mitochondria does play a major role for Warburg effect in terms of cancer, Warburg effect, prostate, and renal cancer. Do you believe it could be that your targets may be involved to regulate the Warburg effect via specific targets like ADME targets or other ones, which does play a role for resistance of cancer or drug therapy?
Maybe we have ever tested several non-cancer samples from the patients. There's a big difference among the patient samples and the tumor samples and the normal samples. There are a huge difference.
Okay, thank you.
You're welcome.
Okay, I don't see any further questions, so I like to close the session, not without thanking all the speakers. Thank you again.
Thank you.
All speakers were excellent, and also for the discussants, and for the audience staying so long here at this Congress site. I wish you all a nice evening, maybe at the Selig evening at the platform, and thank you very much for coming in this evening. Thank you.
Thank you very much.